want to hear you. رامي تقدم الأول نستنى البروفيسور. Okay. Okay. I think ممكن الكل يخش بقى. Okay. Yes. Sorry. Okay. We'll have another cohort, the Egyptian cohort after you. Sarah Ihab will present her cases also. Professor, do you have a presentation or you will talk about it?
Presentation.
Okay. حطينا البرزنتيشن البروفيسور انجي. فين سارة إيهاب؟ حبيبي تعالي هنا قدام بقى.
Yes.
طيب انا قلت لكم ان بروفيسور بيرنيقود كان كايند يعني ادانا البروتوكول عشان نبتدي الهول بادي MRI من 2016 واحنا الحمد لله مع الراديولوجي ديبارتمنت بدانا على طول 2017 2018 ودكتوره ساره ايهاب. بس طبعا بروفيسور اقول لكم اهميه MRI امتى نستخدمه والانتربريتيشن. انا عايزاكم بعد كده تقروه زي البرين بالظبط. يلا تعالوا قدام كل واحده ودورها لينا. يلا تعالي.
So thank you for the invitation, Nadia. Always happy to come here. We had an interval of a few years because of the pandemic, but it seems to be more or less fine now. I didn't have the exact program for today and my talk. So I have actually prepared a 1 hour presentation, but I will take it just 30 minutes as indicated in the program. So generally, the importance of using muscle imaging cannot be overestimated. And I take one particular case to illustrate that issue. This Norwegian girl had growth pains in the legs and fatigue at age 11. 1 year later, proximal lower limb weakness and very high CK levels. As you can see, muscle biopsy was not diagnostic. No infiltrates, no indication of immune-mediated inflammatory disease. And the panel of myositis antibody was negative in those early days. As they did not have any direct understanding, it was thought that she could have atypical dermatomyositis, and she was then given steroids and cytostatic drugs, but no therapy response. A new biopsy was done, and there was clearly no dermatomyositis. There was some fiber necrosis, so they thought maybe it is a dystrophy still in the end. The myopathy gene panel was performed, but turned out negative, and CK levels still very high. The problem was progressive, so she lost her walking capacity at the age of 14 years. What does she have? Is the question. So I just asked for a muscle MRI study, and here you can see the images. So no clear dystrophic changes as fatty replacement in the muscles on the T1s, but you can see on the, sorry, now I have to go back, on the T1 images, in rectus femoris and in parts of other muscles also, vastus lateralis somewhere here on the side. Not much, but still. There is a signal increase, and this indicated to me it has to be immune-mediated despite the negative biopsies. And we have one disease in particular, as I already indicated, doing this, and that's the HMG-CR antibody related immune-mediated necrotizing myopathy. That was then on my behalf requested and turned out to be positive. So she has immune-mediated necrotizing myopathy due to these antibody reactions or associated with it. And she then had the proper treatment for that type of myositis, the IVIG, and had a very good response, so she started walking again. The reason for that not having been tested before was that this was not identified until just 5-6 years ago, and especially it was not known to be affecting children. And now this is known in many, many other cases. Yes, yeah. The interest overall of the technique is, of course, that you can see changes that you can't really get any hands-on by any other techniques. So you can see changes in muscles that you can't go into and see what they look like. MRI is most effective. You can use ultrasound, but it's investigator independent. But in the pediatric setting, to know what a hypotonia is caused by, if there is a neuromuscular disease or not, or brain, it is still important. If MRI for one reason or another is not possible to do, CT can be done because it picks up the fatty infiltrations. The changes on MRI are different in the myopathies and dystrophies compared to the myositis, as you already saw, and also compared to the neurogenic backgrounds. And then we come to the pattern of differential muscle involvement, which in myopathies and dystrophies has a high diagnostic value. And this should be extensively used in all settings where you deal with neuromuscular diseases. Now, in the past at least, not all radiologists were acquainted with using muscle MRI and were not happy with interpreting the findings. So I indicated, at least previously, that clinicians also may need to learn how to read the findings. And to me, it should be a routine examination actually for all neuromuscular patients after the clinical evaluation. When you order EMG and CK, you should also order muscle MRI. The second part of the interest of the technique is that it is a very useful tool to target the best place for your muscle biopsy. And it can also be used for evaluation of the therapy response in myositis. It is largely also used for outcome measures in therapy trials, but that is, of course, if you are just involved in specific therapy trials. The diagnostic protocol, as indicated, whole body is preferred if available. The rapid routine is to do just axial T1 and steer sequences over pelvic, thigh, and lower leg muscles. New techniques based on Dixon protocols increase the potential because you can quantify things, especially for the outcome measures. If you compare whole body study with lower limbs, you do not get 2 times more information with whole body because so many muscles in the upper part you can directly access. Test individually the muscle strength, as in triceps or bicep, and you can see the muscle, and it's sort of accessible by other means. Whereas hamstring muscles you can't access individualized by clinical methods. Other clear values, diagnostic values, is of course then in the whole body you can get hands-on changes in muscles you can't see or get on with your hands, like subscapularis, pterygoid, tongue, paravertebral muscles, and latissimus dorsi. And of course, the whole body is also interesting for scanning for unusual inflammatory changes. If you don't see anything on the lower limbs, you can have something in the upper body. And there are dystrophies that take particularly parts of triceps, for example. So these are, of course, things that need whole body. This is just to show you what the Dixon technique means. You can have an exact number of the fat fraction. MRI also provides you insight in the pathomechanism of the myopathy or dystrophy, like here in FSH, when you can see directly, for example, here the biceps femoris short head does not show any changes on T1, so it's not fatty replaced, but you can see heavy isolated edema signal, and you know in FSHD you have early also inflammatory part, and then if you take the same pictures 3-4 years later, the muscle will show fatty degenerative changes. And of course, I would just point out, if I would not know anything about the patient other than seeing this image of the thigh muscles, I would guess this has FSHD disease. Why? Because of the peculiar asymmetry. You can see rectus femoris on the left side here normal, and on the right side heavily atrophic. And the same thing with adductor longus, even hypertrophic on the left side, where it is atrophic and replaced on the right side. This type of asymmetry is actually not seen in any other disease. So it has to be FSH. Also, you have different causes of muscle weakness. The normal thing with muscular dystrophies is, of course, that you have loss of functioning muscle tissue, and the muscle tissue is replaced by connective and fatty tissue, which causes the degenerative fatty replacement on MRI. But in myotonic dystrophy, we have the congenital forms, which starts from birth or very early, where you have severe weakness. But as you can see, there is no dystrophic change. There is no fatty degenerative replacement of muscles. So the weakness is caused by something else than loss of muscle tissue, as compared to the 40-year-old patient with the same degree of muscle weakness about, where you can see this is caused by loss of muscle tissue. But in the congenital case, as we now know, what happens is that that mutation causes a long range of genes to do abnormal splicing. So several hundreds of other genes are affected, and these genes have then a splicing character which makes out of these genes a fetal isoform, which is different and non-functional. So we have sarcomeric proteins that are sort of have a fetal signature, and they are not doing well. They are not making the strength and muscle capacity in the same way. And that's the reason for the weakness. So just to take a few lines on On the other types of muscle diseases here, again, the myositis caused by antisynthetase syndrome and YO1 associated antibodies. You can easily see there is no fatty replacement in muscles. They look age-related, more or less normal, whereas you have extensive edema changes in the muscles. The same with SRP, antibody-mediated, immune-mediated necrotizing myopathy. No actual changes on T1 signals, sequences compared to the age-related situation, but massive, fluffy edema changes. Fasciitis can also be assessed by this technique, which is a rare condition and difficult to know how it works. Inclusion body myositis, I'm not sure how many patients you have in Egypt, but it's the most common muscle disease in elderly people in Europe. So we have prevalences such as 7 per 100,000. And it is not an easy diagnosis, especially if you do not have access to muscle biopsy. But imaging can give you the clue. What happens is that you have atrophy, you see loss of muscle tissue in quadriceps, and also fatty degeneration of that muscle. And you can see, of course, clinically that the quads are atrophic. And at the same time, you have edema in these same muscles. And that combination is rather specific for this disease. On the lower legs, you have anterior compartment and medial gastroc taking up the signal increase. So what about neurogenic changes? We have been discussing that here along the way with the case presentations. The thing is that if you have ongoing neurogenic damage, especially sort of highlighted in the acute phase of nerve damage, you have a signal increase on stir signals sequences in the same way as with the myositis. You see a heavy increase here, but that is not caused by inflammation. It is caused by vasodilatation. So the blood vessels are sort of losing neurogenic control, and they contain more water, and that is then reflected in this effect. If you take a chronic form of neurogenic damage, as with Kennedy SPMA disease, which has been going on for 20, 30, 40 years, the situation is very different. You have this diffuse changes in all muscles all over, and practically no indication of heavily ongoing. There can be some signal increases at some points, but mainly you just see the diffuse neurogenic changes. There are some pitfalls, and you can have a pseudo-dystrophic change if the neurogenic motor neuron problem developed during muscle development. And then the issue takes another sort of line of changes. You have large areas of fatty changes, but the situation is that these muscles never could develop because of that motor neuron problem in the developmental stage of the muscles. Instead, you have some peculiar parts, islands of surviving muscles here and there in these regions. And that is now also recently reported in a paper officially that this is a diagnostic clue. For example, besides this polio case, we have this also in small head, so lower extremity predominant SMA, where the problem starts or is mainly in the lower limbs, and you have this heavy atrophy clinically, and if you take the MRIs, you see these peculiar islands of some muscle tissue here and there dispersed in the region where you otherwise do not have any muscle. The other part of the whole interest with muscle MRI is to have diagnostic clues directly on which gene can be responsible for the disease. And that is, of course, concerning the muscular dystrophies. Distal myopathies are actually also dystrophies, although they are called distal myopathies for historical reasons. The other part of this is not to have the early indication of what gene could be responsible for the disease, but also a second line. So when you have the genetic results coming back and you have some variants of unknown significance, you can't decide what they mean, if they are important or not, then you can use MRI together with the clinical picture to see if that gene and variant fits the changes and phenotype or not. So just a few examples. We have laminopathies, LMNA gene mutants. We have two different types of here displayed, more conventional type here with this patient. You see very selective involvement and sparing of muscles. So you have selective sparing of rectus femoris, you have sartorius, gracilis, and short head of biceps femoris. And even if the situation in a milder mutation, a milder case, can be very different clinically, you can sort of see parts of the same sort of pattern with the sparing of the rectus femoris and these adductors. Another part here, just a side effect, you can see the lipodystrophy in this case, whereas this guy did not have any lipodystrophy. But if you see this heavy degree of lipodystrophy, it makes you also think of this form of laminopathy. Here, just to show you members of the same family, no, two are from the same family, in fact, and two are from other families. Patients with mutations in DNA JB6, the co-chaperone, they all have the same type of mutation, and you can see reproduced the pattern of involvement. So you have on the lower legs, you have soleus and medial gastrocs, combined with on the thigh, you have biceps femoris long head and semimembranosus as the most involved, also adductor magnus. And this is repeated in all patients, and it is a sort of pathognomonic pattern, and if you see it like that. Kalpainopathy is very different in a way. you have the severe replacement in the calf muscles. Here different degrees of severity. In the mildest case, just medial gastroc, but in the severe case, all calf muscles are gone. And on the thigh level, the posterior compartment in total. So adductor magnus and all hamstrings are involved. How much time do I have? Nadia?
Sorry?
How much time? I do not have a clock here.
It's okay. We are enjoying.
Just tell me where to stop. So
No, please.
because I don't see
You
a...
are following or you slept? You are following. They are very
Okay,
interesting.
okay. We will continue somewhat. Dysphalinopathy shows a very different picture as compared to the calpainopathies. You have on the thigh level both anterior and posterior involvements, not the selective posterior compartment. And here you can see the evolution with age. So at the age of 50, all muscles are more or less heavily destroyed, but at the age of 20, you just have the early changes. And on the lower legs, you know, dysphalinopathy causes mainly the posterior group again to be involved, but later on all muscles are involved. The sarcoglycans are very different to both calpainopathies and dysphalinopathies. You have extremely large changes in proximal muscles. So thigh and pelvic muscles are just heavily replaced and affected, whereas compared to the lower leg muscles, there is just minor early changes. And those that are present are more in the anterior compartment. FKRP is usually not causing any problems for children. It is mainly with the main mutation in European populations. It's a later onset disease, but if you have nonsense variants in this gene, you have also childhood forms. And here again, the changes are very different to the previous ones, as the first muscle to be affected is adductor magnus. Anoctamin 5, I don't know how much you see that in Egypt. Maybe not, because it is in some countries in Europe the most common limb girdle, and that is due to some founder mutation effects. And if you don't have that founder mutation, then you don't see this disease. So we can skip it, but just to show you here, you can use it for follow-up, so the changes over 5 years, how they develop. And this is, of course, then a milder type of limb girdle. But we have another phenotype with that gene, and that's a distal myopathy. Earlier onset and peculiarity with rarely seen in distal myopathies is the asymmetry. So the left calf is severely atrophic, whereas the right side is much better off, and you can also see it on the MRIs, where on the left side you have both soleus and medial gastrocs atrophic and fatty replaced. On the right side, only the medial gastroc. Just taking us to the group of distal myopathies, one of our favorite parts of the muscle diseases. Here I can't go through all these individually, but just tell you that we have one group of genes that particularly affect the anterior compartment muscles. So we have the normal, the most usual form of distal titinopathy. We have the slow myosin heavy chain. We have GNE, nebulin, VCP, and desmin. On the other hand, we have other genes that particularly affect the posterior part, the calf muscles. So we have dysferlin, we have ANO5 as already indicated, myotillin is in there, we have a specific form of filaminopathies in the N-terminal part. We have described a new form of ryanodine receptor gene defects with this medial gastroc dystrophic change, mild disease. And some genes tend then to early on take both anterior and posterior compartments. And we have the Wilander distal myopathy, we have SAST-LBD3, we have a recessive form of earlier onset distal titinopathy, which also takes soleus very early on together with the anterior. And we described the first cases of distal actininopathies, and Matrin3 is in this category as well. So just to show you our most common muscle disease in Finland, caused by a founder mutation in the last exon of titin gene. Again, just to show you, okay, we have varieties, individual varieties, of course, even with patients with the same, exactly the same gene and same mutation. There is individual variety because the effects of the gene defect is then sort of adjusted due to other protein variants. So, for example, here we have the typical form, late onset, 65-year-old, anterior compartment muscles totally destroyed, so no dorsiflexion of ankles, and then some hamstrings muscles, and peculiarly the gluteus minimus muscle is selectively taken away. And here the milder form and the severer form. So we have, of course, this variety you need to consider. If you have this same mutation in homozygosity, it creates a totally different disease. Childhood onset, severe limb girdle, and you can see here at the age of 58, there is no muscle left at all. Some complexities, I think I will end with this just to show you how you can sort of continue to identify new types and clinical subtypes. We have a new type of recessive titinopathies where the previously related distal myopathy gene defect in the last exon, if that is combined with the recessive missense mutation in the A band of that gene, we for some reason get a totally different phenotype. So we have adult onset proximal muscle weakness, with, as you can see here, quadriceps is more or less destroyed with remaining hamstring muscles, and on the lower legs, soleus is taken away. So we don't understand why this happens in this way, but the combination makes a totally different phenotype to what we previously knew of. And again, complexities with titin. If you have mutations in a specific exon in the A band, in exon 344, the muscles that are taken out and fatty replaced are different to the previously known other titinopathies. Why? We of course do not know, but this is how different muscles use the proteins in different ways. So in H-Murph disease, we have the combination of obturatorius muscle, semitendinosus, and tibialis posterior. Here in a younger patient, you can see this combination, and that combination is not present in any other disease. I think I will thank here.
Thank you so much. Because now we will enter in new mutations and how the MRI will help to diagnose new diseases. I think just I want you to diagnose first, then they will have the challenge to do this. Thank you, Professor, so much. And every day we hear you, we learn new and new information. Dr. Sarah Ihab, you will have only 15 minutes or 10 minutes. She will show, okay, 15. Sarah Ihab was the first one in her doctorate degree thesis to apply the MRI muscles, whole MRI muscles, for her cohort of muscular dystrophy in Egypt. So Sarah can show us her patients. You don't need to describe a lot because Professor already told us about MRI. So Sarah will show you her patients. Still we are awaiting for her defense. I hope near soon. Okay.
First of all, I want to thank Professor Ott for honoring us today. And I want to thank Professor Nagia. She's my mentor, and she's the only one I've learned everything from. Thank you, doctor. Today we're talking about muscle magnetic resonance imaging in the diagnosis of LGMD, Ain Shams University experience. I prepared an introduction, but I'm going to skip this. Limb-girdle muscular dystrophies are a group of rare, highly heterogeneous autosomal neuromuscular disorders. There are variable. This slide is showing the pathogenesis of the muscle disorders, all types of muscular dystrophies. Here are the proteins which are responsible for muscle disease. We have a new classification for limb-girdle muscular dystrophies. Here we are comparing between the two classifications, the old one and the new one. We have more than 40 genes causing limb-girdle muscular dystrophy. There is a heterogeneous group of clinical symptoms in limb-girdle muscular dystrophy patients. Clinical symptoms are variable due to the heterogeneous mutations in the genes. Here we can see a case of calpainopathy with marked winging of the scapula and atrophy of the calf muscles. This patient has cuff pseudohypertrophy, is a sarcoglycanopathy patient, and this patient has dysferlinopathy with atrophy of the anterior compartment of the thigh and the leg, and atrophy of the shoulder girdle. For diagnosis of limb girdle muscular dystrophy, we need to do clinical history, general and neurological examination, laboratory diagnosis by serum CK, which is high. It might be very high, about 10,000 or more, and sometimes it is mildly elevated. Muscle biopsy shows dystrophic changes like those of Duchenne muscular dystrophy with muscle fiber degeneration and regeneration. And we use immunoanalysis, which is consistent with genetic diagnosis in 2/3 of patients. This is a muscle biopsy of a dystrophic patient. Here are phagocytes. Inflammatory cells in between the muscle fibers. There is variable fiber size and focal fiber necrosis. Then we can do the radiological diagnostic measures, muscle ultrasound, CT, and muscle MRI. The last step, we do next generation sequencing, which identify 40 to 60% of LGMD patient subtype and help the diagnosis of atypical patients. But last, we can do whole exome and genome sequencing for undiagnosed patients. Ultrasonography, this is the appearance of a normal control patient here. And this is a dystrophic muscle. CT is not commonly used nowadays because it doesn't demonstrate deeper muscles, and the ionizing radiation is harmful and low sensitivity for the muscle edema. The whole body MRI is now done for our a protocol for all our patients in the outpatient clinic. It is used for diagnosis of muscular dystrophy. We can detect a pattern of muscle distribution, which can give us an idea about a provisional differential diagnosis for patients of limb girdle muscular dystrophy. It is used also for guiding us to take a muscle biopsy from an appropriate muscle, detects if there is muscle edema. It narrows differential diagnosis before muscle biopsy, and provides high soft tissue contrast for assessment of striated muscles and great anatomic details. We can quantify muscle pathology to monitor treatment effect. During our assessment of muscle MRI, we use a mercury scale modified by Fisher. Where it is used to grade fatty infiltration by semi-quantitative score. This is the score we use for identification of fatty infiltration in muscle. This muscle is black and T1, so it takes a score of 0, no fatty infiltration, 0. 1, less than 30% fatty infiltration. 2, from 30 to 60% fatty infiltration. 3, more than 60% fatty infiltration. And 4, complete fatty infiltration. These drawings demonstrate the muscles affected, patterns of muscle affection in each one of the most common limb girdle muscular dystrophy subtypes. We have this pattern for calpainopathy, mainly affection of adductor magnus, semimembranosus, and semitendinosus. In dysferlinopathy, it takes the fatty infiltration, involves the adductor magnus, semimembranosus, and vastus lateralis. In sarcoglycanopathy, we have anterior and posterior compartment affection with sparing of the gracilis and sartorius muscles. This is the fucotin-related protein, LGMD R9, fucotin-related protein. There is affection of adductor longus, adductor magnus, semimembranosus, and biceps femoris. In NO5, there is, it is characterized by asymmetry between both sides of both lower limbs. There is affection of the anterior and posterior compartment as well, but more in the posterior compartment. In geniomyopathy, we have affection in the anterior of the thigh and the medial and posterior muscles, in the leg, anterior tibialis, and in the pelvis, in the gluteus minimus, which is characteristic. In Ain Shams University experience, our aim was to identify the role of muscle MRI to be used as a tool for diagnosis, differentiation of patients with LGMD as a guidance for the needed immunological and genetic studies to confirm the diagnosis. We took our patients from the neuromuscular unit, neurology, myology clinic, Ain Shams University Hospital. We had 86 LGMD patients were enrolled in our study with clinical criteria of LGMD diagnosed by clinical laboratory investigation and dystrophic muscle biopsy from Ain Shams University Hospital in our neuromuscular lab. MRI was done blinded from the results of muscle biopsy, immunohistochemistry, and genetic studies. We took a control group of 5 patients with matched age and sex. All patients had full clinical assessment and manual muscle testing using the standard medical research council scale. We made family pedigree for every patient, laboratory investigations with serum CPK, neurophysiological studies, muscle biopsy, genetic studies in some cases, and whole body muscle MRI. Our patient, the MRI machine in our Ain Shams University radiology department is 1.5 Tesla. We took T1, T2, and the stir technique. The stir technique is used to detect muscle edema. We made the whole body MRI. We took axial and coronal cuts. Axial cuts as a shoulder girdle, mid-arm, forearm, mid-forearm, pelvic girdle, mid-thigh, and mid-leg. Our results showed that we had 37 female patients and 49 male patients. We categorized our patients into 4 different subgroups of LGMD based on provisional clinical diagnosis. The dysferlinopathy group sarcoglycanopathy group, calpainopathy group, and miscellaneous group, which consisted of rare types of LGMDs. The dyspherenopathy group had 28 patients were included. 19 patients had fatty infiltration pattern, which was consistent with dyspherenopathy and MRI. 7 patients had MRI pattern of gene myopathy. Next generation sequencing was done for 18 patients. 7 of them had mutations confirming the diagnosis of dyspherin mutation. 1 patient is still pending the results, and 5 failed to detect the result. 3 patients were confirmed gene myopathy, and 1 patient turned out to have calpainopathy. I have examples of patients from the dyspherenopathy group. I'll present a resume about the patient. This patient is a 26 years old male patient, non-consanguineous, no consanguinity in the family history, no similar condition. The onset of symptoms was at the age of 14 years. He has proximal more than distal weakness. He is currently still ambulant. The serum CPK was 19,000 at time of assessment. Muscle biopsy was done and it showed dystrophic changes. Next generation sequencing showed dyspherin gene mutation. Doctor, should I demonstrate or ask someone, or what do you think? Should I demonstrate the MRI?
It's okay.
Okay. Here, we can find that there is fatty infiltration in the gluteus maximus muscle. Here, the gluteus maximus.
This is a fat up, but this is a down. Is this one?
Here we have the fatty infiltration in the paraspinal muscle.
Gluteus maximus, can you, yes?
Here is the gluteus maximus muscle, I'm sorry.
Slightly asymmetrical. Slightly asymmetrical.
The main site of fatty infiltration is the posterior compartment of the thigh, adductor, and here in the gastrocnemius medial.
هي زي ما بتورينا ساره كده زي الديمونستريشن في الاول. early بيبقى فعلا selecting some muscles. late ممكن يبتدي ياخد other muscles، ودايما at least لازم نشوف الثاي مع الليج، لان الثاي and the leg levels بتورينا اكتر.
هو للاسف مش واضح على السكرين، بس واضحه هنا اكتر. اوكي، هو الجاستروكنيميوس الميديال هيد and the soleus grade 1 or 2. The shoulder girdle is spare, and there is a starting affection of the quadriceps muscle.
And this proved genetically to be
dyspherenopathy.
Next.
Patient number 2 is also a dyspherenopathy patient.
You can describe your patient so that احنا عايزين.
Okay. 28 years old male patient, positive consanguinity, negative similar condition, age of started weakness 18 years. He had distal more than proximal weakness. He is still ambulant. Muscle biopsy was dystrophic with Thiamine Deficiency in immunohistochemistry. His serum CPK was 9,000. And the next generation sequencing showed the gene mutation of the dyspherin gene.
So this is distal type, a
posterior compartment
posterior compartment واخد mainly
of the thigh and the leg.
soleus.
Yes. Soleus.
Myoshi type. اللي هو الديستال ميوشي type. Posterior.
He is complaining already of distal weakness, not proximal.
We have some families of gene myopathy in Egypt.
Yes.
And it runs autosomal recessive, and we started to find more and more after whole exome sequence. Can you describe this?
This patient was coming in early onset, He is 27 years old, male patient with positive consanguinity, but no similar condition in the family. He had distal also more than proximal weakness. The muscle biopsy showed dystrophic changes, which were mild dystrophic.
You show us the leg and the side.
Here in the leg, the affection of the fatty infiltration is occur in the anterior compartment, not the posterior here. The posterior compartment is completely free. The gastrocnemius and soleus are free.
Usually takes the tibialis anterior.
Tibialis anterior and the
I would
posterior.
say this is unusual for GNE. I would not be 100% if the mutations identified are not previously clearly reported. But what you see here is rather selective involvement of EDL, so extensor digitorum longus, just a small part of anterior muscles. And
the posterior compartment of the thigh.
To some extent, but also uncharacteristic, I would say. What was the age of the patient, you say?
He is 27 years old. The onset was before this by 2 years, only 2 years.
Onset is 25 years old.
Usually they have even earlier onset. So I would be a bit hesitant, but just by looking at it.
شكيت فيها لان طبعا اوكي
هو
maybe because in GNE اللي هو anterior tibial muscular disc اللي هو Nunaka type. Usually it takes the tibialis anterior and it takes the posterior side as professor showed us. So this is not the tibialis anterior. This is extensor digitorum longus. So it is not the case, but we have to revise the genetic mutation, maybe unusual case. Okay. I have some forms, maybe
Yes, we can. And
we do all in Center G,
طب
so I'm not sure.
I have a question. What if the patient came and we made the MRI muscle very early in the onset?
early, yes.
Then he develops fatty infiltration in other muscles. We should repeat the MRI muscle then, or what?
So the normal situation is that they have this foot drop already
he has foot
before
drop.
before age 20. That's the normal. Of course, you have variations. You may have your own mutations that have sort of other phenotypes, but but we can go over this.
And some of these patients came with severe pains. I have two sisters like this and proved to be Gene myopathy. We have to revise our patients.
This patient is 29. Okay. 29 years old male patient with positive consanguinity and positive similar condition. He's 29.
29, and the onset?
The onset was the age of 3 years. 3 years before he...
26.
26. So our patients are older. What you find on the right, yalla big level. Show us with pointer. Yes. دي بقى بندور عليها. tibialis anterior.
Here you have more extensive anterior compartment.
Posterior
and
compartment.
posterior,
And the gluteus minimus is affected here.
This is typical Gene.
More
More typical
likely.
Gene. There will be quadriceps sparing. Quadriceps is not affected, and usually the posterior side compartment. The most important, what causes foot drop is a tibialis anterior fatty infiltration.
Yes. The sarcoglycanopathy group included 33 patients. Next generation sequencing was done for 13 of them, with positive mutation confirming the diagnosis in 4 patients only. 7 patients' results are still pending. One patient turned out to have glycogen storage disease. He had calf pseudohypertrophy, and we thought he was sarcoglycanopathy. One patient turned out to have Becker muscular dystrophy, although he did MLPA before our assessment, but it was negative. One female patient was found to be Duchenne muscular dystrophy manifesting carrier. Patient.
Describe this, please, Dr. Sarah.
It is a female patient, 37 years old, with positive consanguinity and positive similar condition in 3 sisters. Age of started weakness was at 11 years, with proximal more than distal weakness. She is currently inambulant. She had calf pseudohypertrophy, and CPK was 2,300. Here, she has marked fatty infiltration in all gluteal muscles, biceps, and the thigh. Nearly all muscles except the sartorius and gracilis.
This is
Somehow.
Professor Ochoa.
No, a slide.
Take a global
Yeah.
fatty infiltration,
Yeah.
especially late of the most of the muscles, sparing the sartorius and gracilis. What is in the
Unfortunately, due to she has marked contracture in the knee joint, so they couldn't take cuts in the leg level.
But you have the upper limbs and you have the paraspinal.
The biceps muscle,
mainly,
and
paraspinal muscle. Can you show us the paraspinal?
Sanya. Here,
What do you see?
Yeah.
and the shoulder girdle as well is.
So, with that age of onset, this should be alpha sarcoglycan and not any of the other sarcoglycans. What gene?
2C, yes.
Yeah.
Yes.
Okay.
This is common in Egypt. We have
She is.
three patients due to consanguinity,
Yeah.
sarcoglycanopathy, especially
There are
the
three sisters
three
affected
sisters
in the same case.
and proved to be what type of sarcoglycanopathy?
2C, LG,
Alpha.
alpha.
Alpha. That come very early is the alpha type.
No, the others are earlier and more severe.
Okay. Alpha is common in Egypt, I see.
Yeah.
Yellow.
The second patient with sarcoglycanopathy, 19 years old, female patient with positive consanguinity as well and positive similar condition in her sister. The age of starting weakness at 9 years with proximal more than distal weakness and calf pseudohypertrophy, winging of the scapula. She's still ambulant. The CPK, at the time of examination, she was still ambulant. The CPK was 2,000. Muscle biopsy was dystrophic. And next generation sequencing showed sarcoglycanopathy.
Same pattern as if the same. شايفين الباترن؟ خلوا بالكم الام ار اي ممكن يوجهنا even before the genetic study. هو ده الايم of the study of Dr. Sarah. Same.
Here we have the thigh level, marked affection of the posterior compartment and the anterior compartment as well, with sparing of sartorius and gracilis muscle, the biceps brachii, the shoulder girdle as well. The deltoid is somehow not affected. Here the glutei and the leg. Mainly posterior compartment of the leg.
The TBS anterior is not affected.
Yes.
Can be
Posterior
variable,
compartment only.
but, it can be variable, but the main sort of issue here is to see that the thigh muscles are much more involved than the lower legs,
Yes.
Thigh is
which
much
is,
more involved. Okay.
The calpainopathy group consisted of 13 patients. 4 patients had mutations in calpain-3 gene by next generation sequencing, and 3 patients still pending results. This patient is 18 years old, positive consanguinity, positive family history of similar condition in 2 cousins. The age of started weakness at 7 years of age. He had proximal more than distal weakness, swinging of the scapula, contracture of tendo Achilles and tiptoe walking. The CPK was 8,000. Muscle biopsy was dystrophic, and the next generation sequencing is still pending.
I think it is dysferlin and not calpain.
I would not think of calpine when seeing
Why?
these
Why it is not
MRIs.
calpain? Calpain usually comes the posterior compound. This
Yes, yes.
affection
Both,
the side.
both lower legs and
Yes.
thigh.
But he had very marked scapular winging, very marked.
Yes, but that is with many conditions.
Usually calpain will take the posterior compartment.
Yes.
Not the
He's a very weird patient, actually. He had tiptoe walking.
I think this is something different, and of course we would do a calpine protein Western blotting to check the relevance of the genetic finding.
Actually, we took the patient from provisionally diagnosis by clinical at first. We
will check. He did
yes.
muscle biopsy.
He did a muscle biopsy, but next generation sequencing didn't not arrived yet.
Okay, but
Okay,
this
so
is
you
not
don't.
the typical of calpain.
No,
Yes.
it's something else.
Next. فاضل كتير يا أستاذ.
لا خلاص 3 patients only.
There is something.
طب بلاش
ده
دي.
بقى كالبين. ده كالبين. شيل الأولانية. ده كالبين. اوكي. describe يلا. لا ارجعي لدي. أنا عايزة تقولي لنا الage of onset وتقولي لنا CK level.
Patient 24 years old female.
كام؟
24
What is the onset?
female. At the age of 14.
Okay. First or second decade is okay. What is the CK?
CPK was 2,300.
Okay. It will be in hundreds or 2,000, but it will not be 9,000. This is more with this dysferlin.
She had proximal weakness.
Okay.
She is still ambulant.
Please, دكتورة سارة.
أنا في
بتيجي بالساي بقى. الساي ليفل ده هو الموست امبورتنت.
معلش.
لا. ايوه ده. يلا.
Posterior compartment of the thigh showing sparing of gracilis, sartorius. All the muscles of the posterior compartment are affected, and sparing the anterior compartment.
Mild affection. But mainly it is posterior.
And adductor magnus.
And
And
adductor magnus. انت
Adductor
حتى قلت
magnus.
لنا في الاول قلت الادكتور ماجنس هي الموست امبورتنت even to start with. الادكتور ماجنس والposterior compartment والleg level.
The leg level, there is affection of the medial gastrocnemius muscle, and the soleus, grade 1. The gluteal muscles are less affected than the thigh.
Which one? Medius and minimus?
All
All.
all
What about the paraspinal?
markedly affected,
Okay, and the arm?
and the
Arm and subscapularis.
biceps muscle is affected.
Okay.
Here we cannot. I can't see serratus anterior is affected.
Anterior عشان
It's not.
الscapular.
هي actually
Okay, with calpain. ده اتعملوا genetics.
كانت positive calpain.
Calpainopathy. شكرا. اللي بعد.
The miscellaneous group consisted of 3 patients suspected NO5. One of them turned out to have dysferlinopathy. 3 patients suspected myofibular myopathy. Next generation sequencing was done, and one of them showed mutation causing myofibular myopathy, and 2 patients had myotillionopathy.
What was the result of genetic studies in the case with myofibular myopathy?
الجينيتكس معاك بتاعته.
Actually على اللابتوب مش معايا دلوقتي.
You have many genes.
Oh.
So tomorrow, please bring the genetic study.
Okay.
So Professor Odd will examine it. Is it truly Myofibular myopathy. It's a very rare disease.
Yes.
He has cardiac affection.
Uh,
It is important in myofibular myopathy.
So there are half a dozen of genes causing myofibrillary myopathies and very variable also clinical evolution of diseases. So you can't know just by telling myofibrillary myopathy what the disease might be.
So very important now to examine the genes. Yeah, mytilene.
yes.
So
This
is this a
patient is
dominant
genetic-
family?
Yeah.
Is this a dominant family?
Yes, he is autosomal dominant. He has a brother with the same condition, with a similar condition.
Father and mother?
He didn't say that any other family member except his brother. We didn't know before doing the
Autosomal
genetics.
dominant. We have to examine
Yes, yes.
if they are
He is
still
dead.
alive.
His father is dead.
Yes,
Hmm.
suddenly dead.
Hmm.
So, okay, mytilene, can you describe this, please? What was the age of this patient? And age
This patient is 27 years old. He has the age of started weakness at 4 years.
it's
4
too
years of
early.
age.
Too early for mytilene.
Mm.
Yeah, it's not.
Arsenic,
4 years old.
4 years.
Yes.
Mm.
Myotilinopathy is a late onset disease. So
Autosomal dominant and late
yeah,
onset.
yeah.
Maybe another value.
Yes, this is
No,
why I am
I don't think so.
presenting him. His CPK is 256, and muscle biopsy was dystrophic.
This is something else.
What about the vastus lateralis?
I cannot.
Like a sandwich appearance,
Yes.
that of collagen 6?
No.
No. Okay.
It's too.
We saw
I
patient-
can
Too-
see that all
too
his
much.
muscles are affected.
Yeah.
This is genetic study.
Yeah.
Mytilene.
Yeah, but
Another genetic study will bring tomorrow.
Okay.
Yes, chance to revise your genetics.
Yes.
So bring them tomorrow.
Okay.
Okay. What about
This patient.
this?
This patient is an autosomal dominantly inherited. His father is affected, the same similar condition. He has no consanguinity. It is a boy, 15 years old.
What is the onset?
The onset was at the age of 4 years.
Okay.
He has winging of the scapula, marked contracture of tendo Achilles, which was more on the left side. The CPK was 670. Muscle biopsy was dystrophic, and the genetic study is not didn't occur
could
yet.
be a mild form of collagen 6.
Can you describe the vastus lateralis and rectus femoris to your colleagues? Yes.
Here,
Yes. What do you find?
like lamination of vastus lateralis, like the like
Central part is dark.
is dark and the outside is white.
What they call the sandwich appearance. What about the rectus femoris? It will take like a heart.
Yes.
Okay.
Here.
And in collagen 6, sometimes we found most of the muscles having this appearance of central darkness and the periphery is light.
Yeah.
بس مش not
Yeah.
autosomal dominant.
His
In
father
lam-
is affected.
In laminopathies, we also can see
Laminopathy.
this type.
Laminopathy. So we have to see the genetics to be
Oh,
finished.
yes.
Okay.
Thank you.
شكرا يا سارة واعتبري بقى preparation for your thesis. We need to revise most of this. Thank you so much. So we will return back to the cases rapidly. We will have the first patient with Dr. Rami Taha, our assistant lecturer of neurology at Ain Shams University. How many cases left, Yana? 5 with this patient? Very good. Yeah, we are on time.
Almost.
If you want coffee, coffee.
It's fine.
It's fine. يلا يا رامي.
Good evening, dear professors. I would like to present this case of Mrs. Aras A, 46 years old female patient married with no offspring due to a problem in her husband. He is infertile. The patient complains of gradual progressive muscle weakness that started at the age of 28. Regarding the family history, there is positive consanguinity, distant cousin. Her father died at age of 37 years with unknown cause, while her cousins from father's side died at young ages, 30s, due to cardiac causes. Past history, she was diagnosed as chronic myeloid leukemia at age of 35 years by PCR gene expert for Philadelphia chromosome. Patient was on chemotherapy until now. Patient condition started in 2004 with the lower limb weakness, proximal more than distal, right more than left. And 2 years later, patient developed upper limb weakness, proximal more than distal and more on the right side. She also noticed atrophic changes in the form of scapular winging. 2 years later, patient was diagnosed as CML, incidental discovery by a CBC. After which patient started the chemotherapy and developed sensory affection in the form of burning and tingling sensation of both upper limb till wrist joint and lower limb, only the soles. 2 years later, patient condition progressed to the extent she couldn't even stand alone or even comb her hair. Otherwise, there was no muscular pain, no rash, or no symptoms of cranial nerve affection. Regarding the examination, she's fully conscious, alert-oriented, no abnormality in speech and language. Cranial nerves was normal except for the asymmetrical facial muscles, facial muscle weakness more on the right side, including orbicularis oculi, buccinator, and oris. As for the motor examination, she had atrophy of the shoulder group of muscles involving deltoid, trapezius, supra and infraspinatus, serratus anterior, more on the right side, and there was no muscle tenderness. Hypotonia also was noticed more on the right side. As for the power, she had also asymmetrical weakness, upper limb and lower limb, more on the right side, proximal more than distal, including the same muscles. Supra and infraspinatus, trapezius, deltoid, hip flexors and extensors. There was also a truncal muscle weakness, but no beaver sign. Deep reflexes were diminished with the flexor plantar response. She had waddling gait and intact sensory, sphincteric, and coordination examination. This video demonstrates the facial muscle examination. Facial muscle examination showed more affection on the right side, more atrophy and inability to close eyes.
You can see the patient
ماشي.
around.
That's okay.
Okay, there is facial muscle affection,
Yes.
bilateral,
Yes.
symmetrical or asymmetrical?
Asymmetrical.
Asymmetrical. Okay. There was no similar condition in the family?
No.
No.
young age
Sudden death.
cardiac condition.
Many cardiac
Yes, yes.
and remote or consanguinity of some kind.
We can see the winging of scapula more on the right side. The truncal muscle weakness and proximal muscle weakness. For the labs, creatinine was normal, bilirubin, AST, ALT. CK total was also normal, 174. CKMB was mildly elevated. Vitamin D mildly deficient. Calcium and thyroid profile were normal. Nerve conduction and EMG of both lower limbs showed no spontaneous activity with polyphasia and short duration of motor unit potential with early recruitment, full interference pattern, myopathic. We also did the immunology report. The paraneoplastic autoantibodies showed a positive NTO. As regarding the autoimmune myopathy panel, also showed positive anti-Rho 52. Regarding the echo, was normal, ejection fraction 73%, grade 1 left ventricular dysfunction. Respiratory function test showed mild restrictive ventilatory defect with small airway disease. MRI cervical and dorsal lumbar were normal, only mild disc bulges. MRI muscle was performed, showed bilateral asymmetrical more on the right side muscle fatty infiltration and mild muscle edema. We can see in the trunk more fatty infiltration and the thigh muscles.
Changes of some sort of muscular dystrophy with fatty replacement here and there. We have also in paravertebral, we have some parts of gluteal muscles, both minimus and medius. And then on the lower legs, we have severe replacement in practically all posterior compartment muscles, but less in the left medial gastroc. And more so asymmetry on the thigh level with just sparing of parts of the vastus lateralis on the right side. So very heavy asymmetry on the whole, and of course with this heavy asymmetry you first think of FSH. This is of course the first choice and needs to be checked or excluded.
FSH or
Scapulohumeral
dystrophy.
When you find this marked asymmetry with the facial usually is very important.
And regarding the CML, could it be paraneoplastic?
Chronic myeloid leukemia.
Yes.
For the patient or
Yes, for the patient. Could it be paraneoplastic FSH mimic?
I think it could be.
No, I don't think it, or I have not seen any paraneoplastic issues looking like this without any sort of. Yes, I saw, but
Yes. Okay. This is very important.
yes,
Because Professor, we
yeah,
have another
yeah,
patient
yeah.
with facioscapulohumeral muscular dystrophy and sporadic and proved to be scleroderma. And she has both.
Yes, yes, you can have both. Yes,
Antibodies
I
and
think
clinical and the FSHD.
if the antibody assessment and results are correct, then I think they are independent issues. And I don't see any stir images here, but you would expect some inflammatory changes from the antibodies, but these are heavily dystrophic changes.
After the results of the antibodies,
شد زمايلك ولا يسمعوا. الحقيقه الريليشن between the autoimmune
Yeah.
pathology and muscular dystrophy we started to find in some subtypes. That's why we started to
Okay.
think about this.
yes, and after the positive antibodies, we thought we can start some steroids. Then the patient didn't show any improvement. At first, she says that the pains decreased.
Yes,
Said
yes,
that the
yes, of
pains
course,
decreased,
yeah.
But she gained a lot of weight,
Mm.
and this hindered the movement even more. And she started to have, the proximal weakness
Yeah.
manifested even
Yeah.
more. And also, we were concerned about the leukemia because, with the steroids, we found that some hematological changes as well. So, if there is some inflammatory changes, or we are suspecting with a patient with leukemia, would we
Yeah.
prescribe steroids or?
I don't see the stir images here. They are not included in this package, so I can't
No,
tell.
I'm not talking about the inflammatory
Okay.
change. No, not in the MRI,
Yeah.
but I'm thinking about the positive antibodies, the autoimmune
Yes, but
myopathy.
Anti-Ro only.
Antiro only.
yeah.
What Yusra, anti-Ro, I think it is not specific. It is non-specific.
No, you can have these antibodies without any muscle change.
Without any muscle change.
Mm.
Okay.
But really, I have a patient, sporadic FSHD, and I did for her MRI muscles. It was typical. Then she started to develop manifestations of scleroderma, and
Yeah.
proved the laboratory, and she is treating for this. And throughout the treatment of the scleroderma, the muscular dystrophy is increasing. It does not decrease
Yeah.
on therapy.
Yeah. Two different
Two different
problems.
What about the heart of your patient? This patient, the heart.
Normal.
Normal.
Normal, yes.
Because of their past history. If it's a conduction, you must take care of the conduction. It's okay.
Yes.
And any peculiar things in the even the supportive management? Do you recommend something specific for this patient as regards treatment?
I mean, if this proves to be a FSH,
We have to do genetic study.
then of course there is very little other than rehab measures to make the life easier. We can't correct the disease, of course.
We have a problem in genetic diagnosis of FSH.
Yeah.
Because most of the labs cannot do it, and they don't know to do type 1 or type 2. So where you do your genetic diagnosis?
Even we send our samples to the Netherlands.
To
It's
where? Which labs?
is it
England, okay?
No, we sent to the Netherlands.
Sorry?
Netherlands, Holland.
Netherlands. Okay.
I think Nijmegen or something like that. Very expensive.
Yes. So,
Thank you.
thank you. Do you want to see the patient? تعالى يا رب.
recessive ptosis, the FSA patients have a difficulty to close their eyes. So they can't close their eyes correctly. And many patients have even difficulties to keep the eyes closed in the night when sleeping. So they need to have some drops or, and that's one of the key issues here, of course. Then you have some specific, especially in males, the axillary fault you can check out. And then when lying in the bed and rising up with the upper body and try to do it, you have the B4 sign when the umbilical is moving one direction. And then we have one other sort of rather specific clue for FSH, and that is arm elevation to the side. See here, even without taking off her shirt, is that you have the lifting of the medial part of the shoulder is part of the scapular winging. But when she tries to elevate her arms, you see the movement of this part of the whole trapezius. Yeah. So I would say, just by looking at what it looks like, I would guess this is FSH. And that's, of course, with that family history now, then probably unrelated. And you know that in the previous generations, you can have or may not have any similarly affected parent because of the high irregularity of the mutation. So I would guess that the extremely heavy family history should be related to something else and some recessive disorder. Does she have children? Okay. Okay. No, it was, yeah, no, yeah, okay. If it's this FSHD dystrophy, then there is progression. It will get worse, but not rapidly.
Slow.
Very slow. Yeah. And yes. Yeah. Yeah. And what you can do yourself is try to keep your weight as low as possible, because then you are walking many more years.
يقول لك حاولي تخسي. خلاص احنا هنشيل الكورتيزون اللي تخنك. هو التخاء. يقول لك حاولي تخسي يعني دايما في الكورتيزون. هو السبب. لا هنقل. ألف سلامة. Thank you. يلا next. شكرا يا رامي. بصراحة MRI very characteristic للF SH. Very characteristic. بتسجلوا الحالات دي يا يسرا ولا لا؟ يعني سجلوا الحالات دي عشان لما نبقى نعمل لهم genetic study.
FSH can be extremely variable. You may not have any facial involvement at all for 10, 15, 20 years, and then you get lost. And I have had cases with just lower leg ankle dorsiflexion weakness for 10 years until the other symptoms came around. So just beware of the large variability of phenotypes. But MRI is very informative.
داليا ده اسمه مساعد بقى لسه نايم برضه طيب اوكي دكتور داليا resident neuropsychiatry will present her case.
Mrs. HMS, female patient, married with 5 offspring, youngest is 3 years old. Housewife, lives in Shobra al-Khema with no special habits of medical importance, right-handed. Complaint of the patient, bilateral upper limb and lower limb weakness. Family history, consanguineous parents, second-degree relatives, no similar conditions. Sister has delayed motor and speech development, died at age of 3 after attack of fever. No family history of other neuropsychiatric illness, irrelevant medical history. Family pedigree, this is our patient. The mother.
بعد كده الافكتد cases هي اللي تبقى مظلله واللي مش affected cases will not be.
Okay.
عشان نعرف مين الافكتد ومين مش affected. فلما تبقى patient affected هي اللي هتبقى مظلله.
Patient بس. Okay. She had uncle died at age of 3 with normal developmental milestone after an attack of fever, and aunt died at age of around 3 to 4 برضه after gastroenteritis. The patient has one relative, one sister died at age of 3 to 4 after normal developmental milestone due to attack of fever. Other one, a twin. Twin sister died at age of 3 after fever. Patient had delayed developmental and motor and speech development. Past history, patient developed fever at age of 10, diagnosed as rheumatic fever, received penicillin every 2 weeks, was later diagnosed to have penicillin allergy and stopped it. She developed abdominal pain and constipation with loss of appetite and significant weight loss around 30 kilograms over 2 months. Was diagnosed as Helicobacter infection, received treatment and improved regarding the pain. She has history of arthritis and swelling of both knees 1.5 years ago, then seek medical advice with spontaneous resolvement. History of first trimester abortion. No other symptoms suggestive of collagen disease. Prenatal natal motor speech development buzzed uneventful and normal, no other abnormality detected. Past history. History of present illness, she started with gradual onset, progressive course, 3 years duration. The patient developed generalized bony aches associated with bilateral lower limb weakness, proximal more than distal, left more than right, followed a few months later with bilateral upper limb weakness, was proximal more than distal, associated with hypotonia, proximal muscle atrophy. Symptoms progressed over 1.5 years till she became wheelchair-bound. All through history, there was no sensory, no pain, no cranial nerve affection. On examination, general appearance, she had pale lips, nail, no arched palate, no kyphosis, hepatosplenomegaly, bilateral knee swelling, mild, no edema. Cranial nerves was intact. Motor examination, bilateral upper limb and lower limb weakness, left more than right, proximal more than distal, extensor more than flexor for the upper limb, abductor more than adductor, associated with hypotonia and atrophy, atrophy of temporalis muscle, proximal atrophy, deltoid biceps, triceps, with thinner, hypothenor, milder. Lower limb atrophy, thigh and cuff muscles, no guttering, no hair loss of both lower limb, no fasciculation, no hypertrophy. Reflexes listed biceps reflex, lost other equivocal plantar, sensory was intact, coordination or gait couldn't be assessed. Regarding her labs investigation, all within normal except hemoglobin. She was anemic. CK total, CKMB serial measures was normal. Thyroid function normal. Fee vitamin D wanted before. It was hypovitaminosis still يعني pending result جديدة. Rheumatic factor positive. Other collagen profile negative. Tumor markers negative. Pending vitamin B and vitamin D results. She did MRI whole spine with normal. MRI brain no abnormality detected. EMG في 11-20 with normal. Nerve conduction at our department show polyradiculoneuropathy with evident denervation by EMG for clinical correlation. دي الأرقام. استنى.
انا شويه لوست. هي العيله بقى لها قد ايه في الديوريشن؟
3 years.
3 years. How old is she now?
34.
34. يعني بدأنا وهي عندها 31 سنة. Before this she was completely normal.
Yes,
And
sir.
now she is wheelchair bound.
Yes, doctor. Over 1.5 years.
Over 1.5 years.
Hmm.
There was no fever and no.
Preceding الevent لا.
قولي يلا. لا. GIT symptoms before or associated? Before. Is this was investigated like GI problems like celiac disease, like Crohn's disease?
كانت diagnosed as peptic ulcer وكانت helicobacter positive and she was given treatment for helicobacter.
Very rapid, 3 years duration, and through 1.5 years she lost
Stationary
amputation
senses and
with all of this atrophy. Is it really only 3 years? 3 years duration?
she reported this 4 months after delivery. She accounted.
Okay, this was after delivery.
So is there muscle atrophy or just weakness?
Both.
Both? Okay.
Lost cachectic.
But
Looks like generalized cachexia.
yeah, but go back to the EMG. I didn't
One EMG
see
normal
any.
and the
Yes.
other is axonal radical neuropathy.
Hmm.
Axonal polyradical neuropathy.
With denervation.
CK is very low.
Denervation by MG. Yeah.
So no denervation of on EMG means that whatever then makes the muscles weak, it can't really be neurogenic. And
Why can't be neurogenic?
if you, I mean, this rapid evolution of the weakness, you would need to have some denervation in your muscles in order to have a neurogenic origin for the muscle defect and problem.
The EMG is normal?
Yes, one was normal and no evidence of with. So here we have evidence, with evidence. Sorry, I go back.
Okay.
So we have evidence of denervation.
No resting activity, but there is
Yeah, okay,
polyphasia,
Yeah,
prolonged
so-
duration,
yeah.
and incomplete interference pattern. Maybe. There is
Yeah.
no active denervation.
But the last sentence suggests with evidence of denervation. I misinterpreted the previous one. So yes, we have to consider in the first place neurogenic cause. The question is what type of neurogenic background do we have? Because all the genetic neurogenic mechanisms other than motor neuron diseases and ALS do not cause this rapid change.
It must be secondary to any other.
Something, yes.
Nutritional,
I would
nutritional maybe.
I would think of some.
Pure motor, purely motor. We will have a lecture on next Thursday on atypical neuropathies, maybe. But we must search for all the causes.
So was any spinal fluid investigation? Mm.
You didn't do CSF. Yeah. Reham, you didn't do CSF. Reham is responsible. What about the general condition? I found the patient with cannula and looks cachectic, looks fatigued.
Admitted.
عندنا في المستشفى. طب بقية اللاب في انيميا.
في انيميا هيموجلوبين وريسيفد مالتي 8 اخر حاجه 8. she received multiple blood bags يعني.
no blood dyscrasias. يعني عملنا حاجات السي بي anemia of chronic illness, but there is no any and you investigated for malignancy.
احنا بلفي abdominal ultrasound show hepatosplenomegaly, tumor markers normal.
What is the cause of hepatosplenomegaly?
Yeah, so we have a, yeah.
اتفضل.
No in history, no any evidence in history suggest botulism, something like
Suggest
botulism.
Botulism. So some sort of toxic or immune-mediated neurogenic mechanism, yes.
Yes, you said hepatosplenomegaly. What is the cause? Did they
Unknown.
investigated for the bone marrow? Bone marrow
First,
biopsy?
first إن هي anemia of chronic illness. We send another one for senior staff hematology.
Hepatosplenomegaly. ها؟ ايه؟ Suspected rheumatoid? Rheumatoid factor is not specific.
It's not rheumatic arthritis.
عشان الارثرايتس اوكي كل ده ممكن يبقى سكندري لحاجه ثانيه بس واضح ان في سامثينج هو ده كله سكندري ليه وانا شاكه ان عندها نيوروباثي اصلا شايفاها كلها
سيتي
تشتكي.
الشيست فيها وايد
We will examine here.
مفيش صبغة في المستشفى.
في lost reflex.
So, of course, the first question we all need to have an answer for, could this still be some sort of motor neuron disease or not?
Again.
Yes, and of course, the clinical examination will then be of interest. Do we have any indication of upper motor neuron defect or not? It's not obvious from what you have reported, and that will, of course, be of for great interest for the patient to at least have more or less excluded motor neuron disease, because these other rapidly progressive neurogenic wasting conditions, they usually have another background. So the problem with the neurogenic changes are secondary to something, and then at least principally theoretically you could find a treatment, but it's not that easy.
تعالي يا داليا. خشي جنبها كده عشان ما تلاقينيش.
You can almost feel that there is exhaustion and weakness all over, fatigue. So just by looking.
تعالي يا زقي. تعملي لها كل حاجه. تعملي لها الكتروفوريسيس، تعملي لها كل حاجه.
No brisk reflexes.
Illicit?
Early no brisk reflexes.
Brisk?
No.
No brisk.
You have early.
You are searching for upper motor neuron signs.
Yes, I'm just looking for those. So I check the inner plexus and nothing here. Not even in that direction. So
No
it's
upper
just-
motor neuron.
No. Okay, we have some here.
بس هي كده يعني حتى ايفن ممكن لو هيعملوا بون مارو بتاع الهيماتولوجي فين يوصل؟ بتوع الهيماتولوجي يشوفوها. ها؟ شافوها؟ اه. ما طلبوش بون مارو وسمير ولا بايوبسي ولا حاجه. بس هيباتوسبلينوميجالي بالكاشيكسيا دي مش كلها.
upper motor neuron involvement, and that is of course good for her, because then we
will search for other causes.
And there could be a chance of something that could be treated in the end.
There is edema of both lower limbs, pitching edema. إيه؟ ممكن. Why not? Smile. Maybe because it is dependent also. It is dependent.
Immobility,
Yes.
sitting in a chair all the day. I have also, after 4 hours in the airplane, in the flight, I have edema in my feet. Difficulty with my shoulder.
كلنا والله هروح البيت كلنا إجيما النهارده. أيوة تحكي كده. تحكي عشان I ask her to smile.
Yes.
Okay, please. تحكي.
Yes. It's okay, no problem. But of course, her condition makes her not smiling that
Yes. But Riham has a suggestion.
Yes, I was thinking she showed some improvement after admission only on supportive treatment. So I was thinking about thiamine deficiency as it, yes, as it might cause, it's the only deficiency that might cause pure motor neuropathy.
I mean, you could, that is easily checked in, you have the result in a few days when you test it. And I would, and of course the splenomegaly is obscure. We don't have the cause of that.
We have a common in Egypt.
Okay, yeah. So there are a lot of internal medicine aspects that have to be clarified to search for. Yeah.
I'm sorry? Mild pleural effusion? What about the level of albumin and proteins? لا, serum level of albumin and
Yes.
proteins.
Electrophoresis of proteins.
Electrophoresis is okay?
Yes.
She
Okay.
did electrophoresis.
Okay, yeah.
يلا تفضل. Familial Mediterranean fever. Yes, yes, she has fever. Okay.
Yes, there were several cases of fever and severe.
We must investigate
Yeah,
for this.
yeah.
Because it is common in Egypt. Anemia, hepatosplenomegaly. Yes, you are right.
Yeah. But this motor neuropathy, whatever it can be, I don't see that connection to Mediterranean fever, but there can be several issues.
GIT
Yeah. Yeah.
disorders.
Yeah.
Yes, we may need اوكي وشافها يا حبيبي شافها. ها ايه تاني يا ريهام؟
I was my problem was that she had pure motor neuropathy.
Yes.
Yeah.
Very rare.
You are right.
Yes.
And zone.
Yeah.
It's not demyelinated.
Yes.
Yeah.
You are
Yeah.
right. بس انت بس ما بتقدريش تقومي تمشي خالص. خالص. هطلعك بره والله انا مش ناقص انا مستحمله بالعافيه. خلاص؟ هتطلعي بره. يعني احنا قاعدين بالعافيه عشان خاطر. حبيبتي انت تقدري تحركي رجليكي؟ كويس. ما بتقدريش تقفي خالص؟ من امتى ما بتقدريش تقفي خالص؟ من سنه ونص. طب لو في البيت كده سندوكي ووقفتي ما تقدريش. She did MRI muscles. ما عملتش فلاش muscles.
Yeah.
يلا يا دكتور محمد قول لنا دورك اتفضل يا فندم.
ممكن تبقى بورفيريا.
بورفيريا.
بورفيريا يبقى معاها برضه موتور نيوروباثيس وفي نفس الوقت معاها انيميك
سنسوري نيوروباثي ولا موتور نيوروباثي؟ موتور.
معاها كمان انيميا ممكن يبقى سبلينوميجالي.
وعندها كولز.
Yeah. I mean, there are a lot of internal medicine issues that you have to consider with hepatosplenomegaly, and you should just go through all those alternatives.
I agree with you. We must search for all
Yeah.
the primary causes, and this looks to be a secondary, not a primary. But Rehab observed when she had some supportive treatment in the hospital that she is mildly improved. So she's still convinced that is it a nutritional issue like thiamine deficiency.
Yeah.
تبقي زي الفل.
Yeah.
انت هتبقي كويسه بس مطلوب منك حاجه انت وماما.
More
تكتسبي.
more
سنة
investigations
أكتر.
needed.
وبعدين ابحاث بقى. يلا حبيبتي الف سلام يلا على العنبر على طول. لا ان شاء الله ربنا يقومها بالسلامه. مين النبطش يا جماعه في الاسم؟ كلموه عشان يسلع الضغط والنبض ولا العيله محتاجه اي حاجه لو سمحتوا. يلا حبيبتي. Next, we have our assistant lecturer, Dr. Yusra Fahmi. Dr. Yusra Fahmi is one of the eminent assistant lecturer in neuromuscular
Thank you, Professor.
unit, and she's doing a hard work with her colleagues. And she has a project of inflammatory myopathy. She found many patients, doctor, of
Anti-HMGCR.
immune-mediated necrotizing myopathy in children and in adults. So, okay, yeah.
Thank you,
She has, I
Professor.
think, two interesting cases.
Yes, we have two very short presentations who presented with similar
Patients are not
picture.
present, okay?
We have one patient now.
One
He's
patient?
there.
Which one?
Abdurrahim تعال اتفضل.
تعالى.
One of them is present, the other we have leads.
The other one,
He's not present.
But you will.
We'll show the video, yes.
تعبان معلش. تعالى. يعني بص كده وتعالى. ستة اتحسنت خالص. No, he's improved. Yes, you will know. It's very nice.
Running.
Yes. تخنت كده. شفت داخل عندهم.
Steroids.
Steroids. Okay, yeah.
Okay, we have a 37 years old male patient who works as a car mechanic, married with one offspring. He's right-handed.
فين الحالة؟ يلا يا إنجي. أين الحالة؟
Our presentation?
اوكي
Ah,
اوكي اهي تعالي.
He is of consanguineous parents with no family history of similar conditions of neuromuscular diseases. He has a history of left median nerve decompression 6 years ago. He presented with 7 years duration of asymmetrical muscle hypertrophy in lower limbs, slowness in muscle relaxation, along with spontaneous wave-like movement in both thighs. That was accompanied by bilateral lower limb weakness, proximal more than distal, and muscle cramps on walking. 4 years ago, he developed puffness of both eyelids associated with receding of scalp hair and bilateral weakness of the hand. His general examination revealed scaly skin on both upper limbs and lower limbs with areas of pigmentation, puffness of both eyelids. His neurological examination showed symmetrical hypertrophy of upper limb muscles, hypertrophy of lower limb muscles. The right side was more affected than the left side. He also showed proximal weakness, but was very mild with positive Gowry sign. He showed muscle contraction and prolonged relaxation on tapping, positive mounting sign, and preserved deep tendon reflexes with bilateral flexor planters.
But the patient presented with pains يا يسرا. هو جانا presented with pains ولا difficulty of walking?
No, there was no difficulty, no significant difficulty of walking. There was slow in relaxation of muscles and mild pains. Also, he was complaining of rippling movement in the muscles, but we couldn't.
So he came complaining of the rippling movements of the muscle
Yes.
or the abnormal
Movements of the muscle.
but no pains.
No
No
significant
difficulty
pains.
of walking.
Difficulty in relaxation and delayed relaxation and contraction of muscles.
Okay. Describe to your colleagues what you are doing now in this video, please, and
We
what
here-
happened.
We here have
حالات نادرة جدا.
the tapping of the muscle showed positive mounting or positive protrusion of the muscle on tapping.
اللي هي
My
بتعمل
dear.
tapping المصل تروح طالعة عاملة
Yes.
زي you call it mounting? Something like. Okay, where is the rippling?
It couldn't be listed on his examination on time on admission.
Okay.
But he
Okay,
complained
we
of it
saw-
in the history.
We saw
Yes.
this patient in the clinic, I think several months ago,
Yes.
and he had a rippling of the muscle, movements like large movements from side to side, and we said that this could be a type of rippling
Muscle disease.
and we admitted the patient
For investigations, yes. He also had some constitutional symptoms. He had very slow mentation, receding of hairline, and puffiness of the eyelids.
But this is his coloration, or this
Yeah, this is his color, his normal coloration.
يبقى CK لما دخل.
His lab total CPK was of 7,500. 24 urinary protein was elevated. TSH level was above 100 with low T3 and T4 levels. His anti-ANA and DNA rheumatoid factor were negative. We had normal complement levels. His autoimmune myopathy panel was negative. Anti-thyroglobulin antibodies and anti-TPO were negative. ESR with CRP were within normal.
So he's markedly hypothyroid.
Yes.
Hypothyroidism.
With elevated CPK, with elevated
With
total
elevated,
CPK.
Proteins, 24
Hours
hours
protein.
urinary protein, and very high CK level.
Yes.
Okay.
His nerve conduction EMG showed mixed myopathic and myogenic pattern, and he also showed positive decrement response on repetitive nerve stimulation. His MRI whole body muscle showed diffuse myedema with no fatty infiltration. His echo was within normal. His muscle biopsy showed dystrophic changes with many necrotic fibers and macrophage in cell infiltration. His immune histochemical staining revealed faint dystrophin staining and faint patchy sarcoglycan gamma stain.
وعمل muscle biopsy عندنا؟
Yes.
والله. هنراجعه تاني. This is the MRI describe, please.
The images were not very clear, but he showed on the images, yes, some very faint edema, but there was no fatty atrophy or fatty infiltration too.
فين الإديمة؟
هو الستير images على السيستم بتاعي يعني كان فيه very faint, very mild.
مش واضحة قوي. Very mild كده ده بإيه في السوليوس يعني؟
Soleus and gastric.
تحت كمان شاوري على تحتها.
Right.
حاجة
Yeah.
كده برايت
وهنا
كده
there is-
ممكن دي زي ستريكس
So-
كده.
Yes.
ده
Yeah,
الستير اللي المفروض يبان الإديمة أو inflammatory change. اوكي بس المسلز ما فيهاش فاتي
No fatty infiltration.
سي كي عالي. فوق
Yes.
7000. اوكي.
Our question as regards this patient. First, we are currently investigating him for the possibility of myasthenia gravis for acetylcholine antibody receptors and receptor antibodies and CT chest. As regards the positive decrement response and the associated hypothyroidism. But is there any association between dystrophinopathies and rippling disease? Do we need to investigate him, and do we need to investigate him genetically for rippling disease, or this could be secondary to the hypothyroidism that he had?
So, rippling muscle disease was originally described as a clinical entity, and only later the connection to caveolin 3 gene defects was identified, which as a disease was also in the beginning included in the limb girdles as one of the dominant limb girdles, but that has been taken away because the caveolin 3 gene defect patients do not show major dystrophic changes in their muscles. So they very usually have something in their calf muscles, some mild changes. This would be compatible. And one typical finding is high CK level. So if you have the combination of adult individual with the rippling of muscles and high CK levels without any absolutely clear changes of inflammation or very extensive dystrophic changes in your muscle, caveolin 3 would be sort of the first guess. But you can have this rippling also secondary to other conditions. And also some thyroid problems have been associated with rippling, but these are case reports and you can't really know. But just to indicate that this type of activity can occur also in other conditions. But originally, rippling muscle disease was directly associated with caveolin 3.
Yes, but it was also reported immune-mediated cases to be antibodies against caveolin. So caveolin receptor, I think.
Yes.
So that's why a rippling disease could be immune-mediated secondary to this antibody.
But if I remember correctly, I have not seen those patients myself. Okay. But the antibodies against caveolin 3, did that disease also go with high CK levels?
I'm not sure.
I'm not sure.
We have to revise the literature because this is very important. I don't know if they measured this antibody or not, but it was postulated that there is antibodies against the caveolin receptors.
So, Professor, you think that the main pathology could be caveolin gene defect, and the hypothyroidism can...
Yeah, you can have several conditions that then sort of exaggerate the problems.
Okay, so he...
but what happened when you correct his hypothyroidism?
He improved dramatically.
What improved in the patient?
He had significant hypertrophy in the muscles. This improved. Of course, the eye puffness and the general signs improved. The relaxation of the muscle was way better than before therapy.
What about the CK level?
We'll still do the follow-up, but this level, he has already started thyroxine when this level was withdrawn, the 7,000. We'll follow up now after 3 months of therapy. And I also want to ask, do we need to do a follow-up MRI? This one was done in 2019, at the beginning of the disease. Would it be of value, or?
Yeah, if there is an underlying caveolin 3 gene defect, and you have on top then the thyroid problem or maybe something else even, then the changes are not that rapid. So I would even wait longer than 3 years for the follow-up.
So what about the absence of any fatty infiltration in his MRI? Against caveolin?
No, it's compatible. No. Yeah. This type of very mild early changes can be associated with caveolin 3 gene problems.
Last question, Professor. Have you seen any association between the dystrophinopathies or any other... we had an abnormality in his immunohistochemical staining on the muscle biopsy. Is it usually associated with caveolin defect?
I want to see the muscle biopsy. There is
what was the finding?
With macrophage infiltration.
Yes. I mean, that's part of caveolin 3, of course. It's not part of... it's not part of the hypothyroid.
You know what we want to do here? We have to do Western blot to be sure that the dystrophin or the sarcoglycan are affected, which is still...
I would not check those. They are not.
You want to do the caveolin?
Yeah, I mean, you would see on a muscle MRI changes with those genes, but caveolin 3 can be stained by immunohistochemistry and IF.
Positive decrement test. Yes. Okay. But acetylcholine receptor antibodies, okay.
They're still pending. They're still, this patient is still pending.
But I mean, he does not show any myasthenic symptoms. So maybe you're right. Yeah.
What about pyridostigmine therapy?
We didn't give him Mr.
No.
Only during admission. Only during admission. This is not currently. Improves.
Yeah. there is some more comments. Oh, no, okay. I mean, the decrements, again, all are not highly significant that you see, and you can have those also as secondary effects in different types of primary problems. So I would definitely recheck that. I agree that the ptosis is a bit, yes, annoying in this context. So, in fact, if there would be a myasthenic issue, you would expect the contrary to ripplings. And you would not expect increased muscle activity. So the CK levels again is to me the decisive part of it.
He received while treatment the thyroid. He also received oral steroids according to endocrinological recommendations. The endocrinology recommended that he receive hydrocortisone followed by oral solupred as an initial therapy for the hypothyroidism, the severe hypothyroidism.
Antibodies?
Negative. We did the anti-TPO, yes, negative.
So this is the protocol. They give first steroids, then they give.
As initial therapy, yes. While initially they gave hydrocortisone followed by oral steroids. We withdrew them very slowly than the recommendation. They recommended to only start initial therapy, then stop the steroids.
How many milligrams of thyroxine you give him?
He's currently, I think, on 100 milligram of thyroxine.
Okay. But we didn't do follow-up CK.
No.
We have to do CK.
Yeah.
I saw some children with hypothyroidism, high CK in thousands, and their muscle biopsy is dystrophy. And these children improved on giving thyroxine, yes, and over 1 or 2 years, they markedly improved, even returned to normal. But the CK will decrease.
Yeah, I can't remember having seen any hypothyroid people. Yes, during the last 30 years. So
you must write our patient notes.
yeah.
So I think to
But
continue.
in general, endocrinological disturbances may cause a lot of secondary problems too. Yeah. Yeah.
So I think to complete this patient, we have to do caveolin gene study, and
Follow up
if
the
there is caveolinopathy,
Especially if the CK remains high.
we'll follow up the
and
CK.
follow-up CK. If you want to do follow-up MRI, it's okay. If you can do a stimulatory receptor antibody, you can do.
It's pending.
Okay.
Yes.
تفضل.
Can we consider repeating the biopsy after improvement if patients with hypothyroidism can show dystrophic changes in their biopsy?
I would rely much on the CK. If the CKs drop to normal after this therapeutic intervention, I would and stay normal without steroids, then I would sort of discard that. But if the CK stay high, then caveolin 3 is.
يلا قوم ورينا مشيت. روح كده وتعالى. تعالى عشان البروفيسور يكشف عليك. Please go. يلا. Yes, he has to.
Does he know if the face always look like this or is his
طول
face
طول
changed?
ما عمرك عينك جفن عينك سقط شويه ده شكلك من قبل كده من قبل بتاع he's always say this is
Yeah,
how he looked
so
always.
Minor finding, and if it was there already from childhood, you don't know.
يعني هو شايف ان الدوزس ده العيان طول عمره عنده احتمال ما تبقاش يعني حاجه significant. احنا لازم بقى we depend on follow up CK thyroid functions. عايز تعمله follow up MRI it's okay. وبرضه we have to
Genetic
search
testing.
for caveolin
Caveolin
gene.
gene.
بس هو الريبلين كله راح خلاص.
لسه في mounting.
لسه في mounting
موجود
ده
لك
موجود.
الريبلينج موفمنت نفسها it improved.
You have another patient?
I have another very quick patient. He's a 39 years old male patient of
عنده كام سنه؟
39.
39.
Oh, 39 years old male patient of non-consanguineous parents with irrelevant past and family history. He presented by 1.5 year duration of rippling movement of both lower limbs that progressed to involve his upper limbs and facial muscles. Patient also accounted that he occasionally sees objects as two beside each other that improves on rest, but with no evidence of diurnal variation. Recently, he started to complain of pains over the anterior aspect of both his legs. He also mentioned that he sometimes suffers from difficulty in swallowing solid food that improves spontaneously. He sought medical advice and received oral and parenteral steroids, then IVIG with transient improvement, and he is currently under therapy with rituximab.
Yeah. So this is
rippling.
this is more what you sort of would expect with the rippling, yes.
And it is associated not just pains, yeah, Yusra, associated with severe pains and cramps. He said as if my muscles are moving from its place and very painful. This is annoying him and it comes in attacks like pains and cramps and these movements all over his body.
Yes, and he also mentioned that recently he can
Yeah, yeah.
All over his body, 1.5 years
year
on
duration. Yes.
duration.
But also, Professor Nagi is recently commenting on pain even on the bony aspect of his leg, not only in the muscles.
Not only the muscles, the
Yes,
bones
pain and
also.
tenderness.
Can you
Yes.
show us the muscles again? The video again? شو يا جماعة؟ خلوا بالكم ده very rare condition. ده rippling بقى. ها؟ Okay. يلا next.
As regards his investigations, he had a mildly elevated total CPK of 130, normal thyroid function, parathyroid, and vitamin D levels. His tumor markers were negative. He had antibodies done against the potassium channel, the LG1 and the Caspar-2 antibodies. They were negative. His acetylcholine receptor antibody is positive, of 0.66.
Mild elevation.
Yes.
Normal is up to below
0.4, yes.
and they found it to be 0.66. So may account for some of the myasthenic symptoms, the diplopia and difficulty of, but very يعني borderline. Yeah, it's borderline. Okay.
His CT chest showed a middle right mediastinal soft tissue lesion, measuring.
Nerve conduction EMG.
His nerve conduction EMG actually showed only cervical and lumbar radiculoneuropathy.
No myopathy and no neuropathy. Okay. Decrement test.
I don't think
We send him for
we sent him
decrement
for a
test.
decrement test.
Okay,
but
we will check. What you found in the CT chest?
he had a soft tissue lesion measuring 5 centimeter by 4.7 related to the pericardium. The cardiothoracic think that it can be thymomatous tissue.
Can be.
Thymomatous
Thymoma.
tissue.
It could be thymoma.
Yes. But he's still under investigations.
Okay.
So
Next.
the question is, can this patient be...
Actually, before this, one of my colleagues thought it could be a potassium channel.
He did the antibodies, yes.
And he did the antibodies, but negative. But he started to give him first steroids, no response, then IVIG. Maybe he took 4 courses.
Yes, he's had
gave some
very mild transient improvement.
Then in the 3rd or 4th week,
Relapses
started
again.
to have the pains. And then we started to give him rituximab.
Yes,
We
he
took
received his
1
first
trial
dose.
or 2.
First
First
dose,
only.
yes.
And then we found the lesions,
In the CT chest.
mediastinal lesion. Then we stopped. We asked for a acetylcholine receptor antibody. It is borderline mildly increased.
Mildly
What is your
increased, yes.
question, this patient?
Could this patient be immune-mediated rippling disease? Or should we also,
It's a paramalignant.
or should we also search for the caveolin gene, and this can be associated, and whether he will
Yeah,
benefit from immunotherapy or not?
I would expect from a caveolinopathy that the CKs are in the thousands and not below 1,000. So that's one issue. They sometimes, or quite usually, also have calf hypertrophy, which was not evident, at least here. And then, of course, you have in caveolin 3 the mild changes in calf muscles on MRI. So these can be, of course, rechecked, but apparently we have, yes, some sort of, I mean, overactivation in the neuromuscular junction. What it may be is, with this background, very more difficult, I would say, to estimate what it could be. The thymoma, if we have some sort of neoplastic problem, then you can expect whatever, and you can't know. So I would try to clarify the tissue problem in mediastinum first, to know what that is, because it has to be checked anyway. And if it is removed and everything resolves, you are happy.
So we can hold or postpone the immunotherapy till we investigate the soft tissue mass, right? No need to.
I would do so.
Because he may need removal of the mass.
Yes.
He may need radiotherapy. Or
Yeah,
chemotherapy.
whatever, we don't know. We just have to clarify that first.
Yes.
Okay. Thank you so much,
We will
Professor.
wait
Thank
follow
you.
up of this patient with you.
Okay, but no need for MRI muscle or anything for this patient, right?
Check the mediastinum problem first.
Okay. Thank you so much.
دي حالات تتكتب ها. يلا next. Angie is the next. No. Summer is the next. رايحة فين؟ عشان كده. طب يلا مع السلامة. يلا Summer, our neurology specialist and now postgraduate, she will start a big project in malnutrition. I'm very interested in malnutrition in Egypt, and I think it is a cause of many neuromuscular disorders. So we will try to clarify this through her projects. يلا.
Mr. MFM, 38 years old male patient, married with 4 offspring, youngest is 2 years old, lives in Helwan and currently unemployed. Started cigarette smoking last year, 3 to 4 cigarettes per day. Patient has irrelevant past history except for left hip fracture 4 years ago and road traffic accident. Underwent fixation surgery and was bedridden for 2 years. Family pedigree, first degree consanguinity. The patient is the only one with the only one with the disease among the 3 siblings. Irrelevant family history. The condition started 14 years ago when the patient was 24 years old with gradual onset and progressive course. The patient started to develop left lower limb weakness, distal more than proximal, extensors more than flexors, that was associated with foot drop, and left quadriceps muscle fasciculations. The patient reported finding difficulty climbing stairs and walking unsupported, yet he was limping. Few months later, he developed left upper limb weakness, distal more than proximal, extensors more than flexors, associated with atrophy of left triceps and thinner muscles. 6 years later, the patient had road traffic accident and developed left pelvic fracture that required internal fixation surgery, after which he was bedridden for 2 years, during which he started to develop right lower limb weakness, distal more than proximal, extensors more than flexors, associated with right foot drop and quadriceps muscle fasciculations. Few months later, the patient started to develop right upper limb weakness, distal more than proximal, extensors more than flexors, associated with atrophy of right triceps and thinner muscles. The patient was walking bilaterally supported till 6 months ago, when he had left ankle dislocation and became wheelchair bound since then. Neurological examination relevant findings: bilateral upper limb and lower limb weakness, left side more than right side, left distal more than proximal, and no fasciculations. Atrophy of triceps and thinner muscles, bilateral foot drop, diminished deep tendon reflexes all over, bilateral flexor plantar. Investigations: normal CBC, STLT, 1 creat, sodium potassium, CPK 690, TSH, T3 and T4 normal, antithyroid antibodies negative, low ionized calcium and vitamin D, parathyroid hormone, alkaline phosphatase are normal, PCR for SMN1, no homozygous deletion of exon 7 on SM1 gene. Nerve conduction and EMG, there is electrophysiological evidence of a diffuse disorder affecting the motor neurons, anterior horn cell, or their axons. Differential diagnosis: progressive muscular atrophy versus spinal muscular atrophy type 3. هو البيشنت موجود يا دكتور والفيديوز برضه موجودة.
show us a video please.
احنا هنا كنا بنتأكد ان مفيش tongue fasciculations، لان هي كانت مش طالعة خالص في الاكزامينيشن.
No atrophy, no fasciculation of the tongue. Okay, next.
bilateral flexor. هو لا
لقيتي ايه بقى بعد ده كله؟
bilateral flex. انا كنت هي كانت طالعه فعلا جدا.
اوكي.
برضو ما فيش fasciculations.
paraspinal. لا هو احلى من كده يا شيخ، حرام عليك، تصويركم وحش. يلا عاملين الصوره كده.
هو ما كانش في اي sensory affection.
يعني it's a purely motor condition.
بالظبط يا
You
دكتور.
can feel every pinflex arises. And reflexes is lost all over?
all over.
All over is lost.
يا دكتور.
Vibration is intact.
vibration and superficial sensory. deep sensory. احنا mainly distal muscle weakness, bilateral upper distal mainly.
But SMA type 3 is SMA is a proximal disorder, that of chromosome 4 or SMN1. It is a proximal disorder, not distal. There are other types of distal SMA.
Many different.
Yes, another different mutations.
Quite good.
هو mainly extensors more than
Extensors more
flexors.
and this distal. Okay, proximal is good. And the condition is still progressive over 15 years.
14.
14 years. How old is he now?
38.
38. And there is consanguinity.
Yes.
Okay. Face is okay. عملوا فيك ايه ده؟ خلصوا؟
No facial weakness.
ده خلصوا عليك. ماشي. ده مين اللي بتكشف؟ دكتورة رضوى؟
دكتور رضوى.
رضوى خلصت عليك. ماشي. اوكي. مفيش خالص اهو. reflexes deep tendon reflexes. احنا خلاص عايزين نجيب منطقة غير المنطقة بس موجود والله
هو
اوكي. distal is markedly diminished لكن proximal موجود.
Normal.
normal. اوكي.
mainly triceps atrophy.
no fasciculation.
No fasciculation.
بس الترايسبس كانت موجودة؟
لا لا
ها؟
diminished.
diminished. يعني هي البريسك بس
البايسبس بايسبس بس diminished brachioradialis و triceps.
طيب lower limbs
diminished all over.
diminished reflexes in lower limbs.
all over the joints.
What
No,
about the patella?
no patellar clonus and not elicited. The reflex wasn't elicited.
The patient had multiple surgeries in his lower limbs and internal fixation, so it's very difficult
Yes,
to
no,
yes,
yeah.
yes, to
it's
manipulate.
very painful.
Yes. واخر واحد الخلع بتاع الانكل. الناحية الشمال ولا اليمين؟ الشمال. تقدرش تقوم دلوقتي. تقدر تقف بس مش قادر تمشي عشان الخلع. اوكي. لكن ستيل كان ستاند. ستيل كان ستاند بس مش هيقدر يمشي علشان الليفت انكل ديسلوكيشن.
Yes.
No, they're not operated.
No, still not operated. He's for surgery.
Okay,
So, yeah, do we have neurophysiology on him?
We have nerve conduction and EMG.
yes.
It was
motor
motor neuron anterior horn cell.
That was already, it was already clarified. Okay, long history.
Yeah, 14 years.
Slow progression and everything points towards rather restricted affection of lower motor nerves,
Yes.
either as a neuronopathy or a neuropathy, either or we can't know. But the absence of active fasciculations would more make us think of a neuropathy more than a neuronopathy. But the borderlines are not always that clear. So what do we have here? If we think of secondary nerve affections in terms of immune-mediated or paraneoplastic or whatsoever, I would not expect this very long evolution, long history that has already passed and the still prevailing proximal strength. So the first just hypothetical thinking would go into the direction of some genetic disorder causing distal SMA type of problem. And of course, again, the patient is more relieved to know that this cannot be ALS. With that long history and nothing on the upper motor neuron after 14 years.
What is the progressive, the lower motor neuron type, progressive muscular atrophy?
Yeah, so that's
Can be
it.
applied here?
It is just a category. It's just nobody actually knows what to include in that category. It is a category based on phenotyping 50 years ago, and now we would like to have some sort of more distinct names for this just broad category.
So do you suggest to have whole exome sequencing, searching for atypical typical causes genes?
Yes, there are more than 10 genes currently associated with distal forms of SMA. And very frequently they start in juvenile age, early adulthood, very few start in childhood. The disappointing thing is that of our cases we have in Finland, maybe I would guess a total of 30, 40 cases. I think 90% are still unsolved, despite having checked all the currently known genes. So, yes, are still unsolved.
So it is a whole exome, and they didn't find any mutations.
In the currently known genes, no. So
whole genome or whole exome?
whole exome.
Whole exome.
Just take some clinical.
يعني صح. 90%.
So of course, when you see these atrophies, you first think of ALS.
Yes.
Oh, this has to be ALS. But when you go back to the history of 14 years, and definitely no indication of any upper limb. Did I put them?
It was evident more in the video.
We have a response, but just normal.
Yes, okay.
And definitely not exaggerated. And here as well, we have a normal response. So yes, but nothing in the fingers. And then you said you had
Many
some
operations.
responses here, but
No,
you don't know because of the
no.
yes. Yeah.
Upper limb, there was some response in the biceps.
The right side.
Right side, Kevin.
But here you have the other secondary problems, yes. See.
No.
Not much.
And no fasciculation.
No fasciculation. So again, unfortunately, this is not a secondary problem to something we could treat. Most likely. So we have, of course, in that sense, nothing to offer to the patient, but the long history will tell us that his current motor function, including breathing and feeding, will stay good for
So no
long
evidence
times.
of ALS.
No, I would not say so. Yeah.
هو شايف ان الموضوع بتاعك موضوع حميد ويعني مش خطير يعني ومش اللي هو ال ALS اللي هو التصلب الجانبي الدموي ده يعني غالبا هي طفره بسيطه هي اللي مسببه الحاجات دي بس بيطمنا يعني.
So it would be interesting to know, of course, what the legs would look like and whether he could walk if he had not severe other problems in the legs.
We can proceed to orthopedic surgeon to see if he can fix. Yes. لا يعني ليه ما عملكش العمليه بتاعت رجلك؟ ليه ما عملتش عمليه الخلع؟
هو pending لسه هي
لا الخلع بتاع القرار.
مثبتين الجنبين بشريح مصمم.
خلاص يو ديد ذا اوبريشن.
بس هو المفصل نفسه اللي مثبت لنا ما كان عايز يرفع لي مشط رجلي وانا ما رضيتش اثبته. ما رضيتش اثبت المفصل نفسه. انا ثبت
يعني عايز يثبت لك بس لكن انت بتقدر تقوم وتمشي.
الوقت بقى ان انا اخد خطوه بس طبعا دي دلوقتي بقالي فتره كده مش شايلها خالص. من بعد 6 اشهر دول اثرت جامد.
عشان قعدت لازم تعمل he must do physiotherapy again.
Yes, so what is the reason for him not being able to walk?
He had multiple road
Yes, yes,
as,
yes, yes.
as you know, every time with the rehabilitation period, he starts to lose motor functions again and stop all the physiotherapy, and then lots of operations. The last one was very recent, so he has stopped.
He was bedridden for 2 years.
Affected him very much.
Uh,
But then, you know, after a while, he starts. Now he is saying that he starts to improve, and now
Okay.
he can stand.
yes, I
You know,
think so, yes.
A few months back, he
Yes.
couldn't.
So I will would definitely try to do whatever rehab he is managing to do to sort of gain some walking capacity again. And of course, again, as with the previous patient, with all neuromuscular weakness, you need to keep the weight low and not high, because every 10 kilos you have to carry will diminish your capacity to move around. But I don't see any impossibility for him to walk again, at least small distances.
مش كده لوحدي.
He was walking supported
Yes.
before this.
Yes, last accident, yes. Yeah, yeah.
I think that
I would
I think that
try
he
to
must,
do,
he must lose
come
weight.
back to that, yes.
He must lose
Yeah,
weight
yeah.
and start.
And
try to do
all types of
again.
physical activities, swimming, everything that can be done.
Yes.
Yeah.
فهمت الآن؟ سمرة الترجمة. يلا. Thank you, Professor. يلا. ألف سلامة. ألف سلامة. How many cases left يا دكتور رنا؟ واحدة. Finally we are on time أخيرا. Oh, only one case. Our hard worker and very, very helping of patients, Basma, our neuropsychiatry resident, will present the last case.
Good morning, good evening. Can I present Mrs. Hand, 44 years old female patient, married with 3 offspring, youngest is 17 years old, right-handed with no special habits of medical importance. Family history, she has non-consanguineous parent with no similar condition in the family with irrelevant past history. Her condition started in 2016 with gradual onset, progressive course of right lower limb weakness, proximal more than distal. 2 months later, she started to develop left lower limb weakness, proximal more than distal. Furthermore, she started to experience recurrent falls. She sought medical advice, received oral steroid with no improvement. 1 year later, she developed increase in severity of bilateral lower limb weakness, and bilateral upper limb weakness started to develop. It was proximal more than distal. In 2018, she started to develop dysphagia, more to the solid, improved on pyridostigmine, then recurred months later with no further improvement on pyridostigmine, associated with regurgitation of fluid from the nose. She received IVIG 5 days on December 2021. and 5-gram methylprednisolone twice, lost in March 2022 with no improvement. She also started to notice progressive decrease in muscle bulk around both shoulders. In 2021, she started to develop neck muscle weakness, flexors more affected than extensor. All through history, there is no distal muscle weakness, no sphincteric or serpellar affection. Regarding her examination, general examination showing thyroid gland enlargement, movable with deglutition. Her cranial nerves are intact. Motor examination, regarding the state, there was marked atrophy in the shoulder, mainly in deltoid muscle, no fasciculation and no hypertrophy. Patient showing hypotonia around both shoulder, hips, knees, and elbows. Power, bilateral upper limb weakness, left more than right, proximal more than distal. Distal affection was found only in her left upper limb. Extensor more than flexors and adductors more than abductors. Bilateral lower limb weakness, right equal to the left with proximal affection more than distal. Neck muscle weakness, both flexors and extensors, yet flexors are more affected. Regarding the reflexes, upper limb, there was lost brachioradialis, elicited biceps and triceps. Lower limb was lost knee and ankle reflexes. Coordination wasn't affected as much as we could assess. Sensory examination showing bilateral gloves and stocking.
Distal weakness.
The weakness mainly in the left upper limb.
كان واضح البروكسيمال، واضح الابدكتورز. تمام. طيب اللور ليمز. ديستال كويسه.
Distal no affection.
What about the quadriceps?
Affected.
Affected. Why I'm asking about the quadriceps?
Particularly, I don't know.
You know, inclusion body myocytes. I'm thinking about this weakness and dysphagia.
When onset,
Ah.
age of onset.
relatively long duration.
كم سنة؟
In 2016.
Huh?
Since 2016.
Wait, how old is she now?
A bit
14.
too young onset.
Yes.
Bit too young onset.
Huh? 6 years. Okay. هي دلوقتي how old is she now?
40 years.
Huh?
40 years.
40. And started
6 years
34. Okay, it is young, but everything can happen.
Doctor, if she is inclusion body myositis, the dysphagia will improve spontaneously in the course?
No, it's a progression.
Yeah. But at the time when patients with inclusion body myositis have dysphagia, they have quite severe finger flexor weakness.
Flexor muscle
Yeah.
affection. Because you said the distal weakness, that I was thinking about this, but there must be marked flexion. They will have a deformity to
We're
have.
starting to develop
Yes,
dysphagia.
because the dysphagia is a last symptom. But it can happen. I have a patient also, she is young and proved pathologically to have IBM. So, okay.
The investigation, autoimmune myopathy panel done only 2 months ago, showing MI2 alpha borderline and MI2 beta is positive. Her labs,
She has any skin lesions?
no skin lesions at all.
Okay.
High CPK levels, always ranging 7,000, 9,000. The highest level in 2016 with onset of disease was 11,000.
This is very high to be IBM.
Her last CPK
Too,
was
too
20.
high. Mm. Too high.
Too high.
IBM will be only
Up to 1,000.
Yes.
Okay. Regarding the thyroid profile, it was normal, and collagen and the ECR was also normal. She have done 3 nerve conduction and EMG. First one was in December 2016, showing demyelinating polyradicular neuropathy with secondary axonal affection. Second one was in October 2021, showing axonal polyradicular neuropathy. Third one was in May 2022, showing diffuse neurogenic affections of anterior horn cell origin or their axon, and was commenting on fasciculation in tongue and proximal muscle, which wasn't obvious clinically.
Do you accept this nerve conduction? With this very high level of I don't accept.
Clinically, no. She was diagnosed first as CIT.
You have to do by yourself. You will learn EMG now from professor tomorrow. You have to do by yourself. 11,700 and
It's not neurogenic.
It could be mixed. If
Yeah,
you are
can be
sitting on
both.
one
Yeah,
side,
yeah,
it could be
yes.
mixed. It could be associated connective mixed as the patient yesterday. Mixed connective tissue disorder. I have neuropathy, radiculops, and have a muscle disease. But here, no evidence of myositis. It cannot be. You have to do by yourself, and you have to select proximal muscles. You have to select proximal muscles. Maybe they are doing the distal muscles.
Her echocardiography was normal. MRI muscle done, showing bilateral symmetrical lower limb edematous changes with fatty muscular atrophy and incidental bilateral knee effusion.
Yes, so I mean, just by looking at the sections are not optimal, they are very low, so you don't see the gastrocnemius at all. The soleus is totally replaced, and with that combined with the age of onset and high CK levels would make even calpainopathy or anoctamin 5 possible. Okay.
We need to see the psi level.
The gastrocnemius, the lung.
والانتبادي اللي قلتي لي MI وده بتاع ايه؟ dermatomyositis. عملنا اي حاجه المالجنسي؟ دورنا على
She will be admitted next week. This patient received also thyroid, received IVIG, so we're planning for plasma cuts.
wait لما نشوف الانتبادي ده related ولا لا. خمس سنين duration 5 years. اوكي 6 years duration. يعني خلوا بالنا برضو الماسكولار ديستروفي ممكن يبقى فيه ايديما. يعني مش اي ايديما نلاقيها والديسفيرينوبس فيه inflammatory changes.
Highly relevant changes on MRI on the thigh level. You don't have them here?
Okay, show us.
Okay, yes. So what you see here is actually this thyroid changes with more advanced fatty changes in the periphery of the muscles and sparing the central parts, and you have the U sign in rectus femoris. So this would be so we have these thyroid pattern of changes, and here in rectus femoris you have a U sign, which are the very typical changes for collagen 6 disorders. However, they do not usually show these high CK levels. And you have usually some sort of contractions, But there are variations. We have reported a limb girdle phenotype of collagen 6 with also this same MRI findings. And on the thigh level, for a calpinopathy or anophthalmine 5 disease, you would expect more heavy changes in the posterior compartment. So this is really intriguing, and I would keep laminopathy and col6 as candidates. This is definitely something in the dystrophic field and not secondary to something else. Does not look like that. So the genetics would be the main street forward. Did you say anything about the family? Nothing in the family? No, nothing in family at all. And no contractures?
Contractions.
Mm.
Fluctuating course. She had an attack of dysphagia 2 or 3 years ago that improved on mistinone, and then she stopped mistinone and resolved spontaneously. Then she relapsed again now.
Mistinone is a symptomatic treatment.
But she had a relapse for dysphagia now with
Uh,
dropped because this
No, this has to be a dystrophic background anyway, with that high CK level and these MRI changes. So what actually caused the dysphagia, I have no idea. But I have hard times to believe any autoimmune background could or cannot make these changes anyway. So if there was something in the myasthenia field to cause the dysphagia, it has to be a totally independent second factor in that case.
we're aware thinking that she might have an inflammatory
I think to do
Yeah.
the genetic study before giving more and more immunotherapy,
Yeah.
especially she didn't improve on any
Yeah,
modality.
no, I heavily think this should be a genetic muscular dystrophy.
Do for her, then you put in the neuromuscular panel collagen 6, right? But we don't have laminopathy. Huh?
LMNA.
So please, before going to expensive immunotherapy, and it can cause side effects, I think to do the neuromuscular panel first, at least to screen for these common genes. I have a patient, and I did for her the myocytes panel, and it was positive, and I was treating her as this is inflammatory myopathy. Then the MRI changes looks like that of calpinopathy. Then we did for her the whole exome sequencing, and we found a homozygous calpain mutation.
Yes,
So
I mean,
usually the panel
no.
is right.
You can be
I told you
fooled
about this
both ways by immune issues.
We were just in this patient. We were actually concerned with the edema and the MRI,
Yes.
the muscle,
The neck muscle. Okay.
and the dysphagia. That's why we thought of inflammatory origin, and
Yeah.
we were going to proceed for plasma
Some patients not in this patient, like this Ferlin, they improve on steroid and the edema will subside, then CK increase again. So
no need for prevention until we do the genetic diagnosis.
you want to give her what?
I would have.
Postpone any therapy.
Plasmapheresis?
We're postponed.
No, please. Do that.
I would go heavily for the genetics just to. Yeah.
Very interesting case. And this case, you must reach a diagnosis, because if it is not proved to muscular dystrophy, we can proceed and see if it is an intractable form of polymyositis or not. But these antibodies, sometimes it is misleading.
Yes, and these fatty changes on MRI, I cannot understand they could have anything with immune-mediated background to do. But I can be wrong as well.
Thank you, Basna. Okay. I want to thank all of you for your efforts in the cases. And the second day finished, I think Masr Al-Fain has certificate for the first 2 days for the cases, right, NG? I think they have a certificate for the first 2 cases. And tomorrow they will have a certificate for the EMG and nerve conduction study course. We have the lunch now, and tomorrow Dr. Arado has announcement about the room. The room will change tomorrow.
الام دور
ميزانين انتبهوا في الميزانين
هو الام 1 ام 1
الاي ام جي هيبقى ليه سبيشال كورس خلاص ام 1 now you are invited